Okay, Eva Biewald then from Essen, from your center, talking about retinoblastoma, please. Thank you.
Thank you very much for the opportunity to talk to you on salvage therapies in the treatment of retinoblastoma. Sometimes the different non-treatment options are not sufficient in the management of retinoblastoma, and therefore I would like to talk to you in the next few minutes about proton beam therapy as a new treatment approach in pre-treated retinoblastoma eyes. And the last minutes of my talk, I would like to talk about the modified enlarged enucleation via lateral orbitotomy for retinoblastoma with postlaminar optic nerve infiltration. So what are the advantages of PBT if there is non-avoidable radiotherapy? The effectiveness is comparable with EBRT. We have a lack of an exit dose and a small penumbra, resulting in less radiation damage to collateral tissue. And therefore, we hope for a reduction of ocular side effects and the reduced probability of radiation-related induction of secondary primary malignancies. What is our treatment technique? We use two dental markers. They are sutured to the nasal sclera to make sure that the eye is in correct position while PBRT is performed. Then the gross tumor volume and the clinical target volume are defined in cooperation between treating ophthalmologist and radiation oncologist, and then the radiation field is being constructed. For treatment, we used the Proteus Plus therapy machine, and we did a fractionated irradiation with 2 grays per day for 25 days of irradiation, leading to a total dose of 50 gray. Let's have a look at our patients. Recruitment period was from February 16 to August 2018. We included 15 eyes of 13 bilaterally affected children. Mean age was 35 months, follow-up 22 months. Indication in all patients was the rescue therapy in advanced retinoblastoma disease as last option for eye-preserving therapy. Here you see the initial findings, demographic data, and treatment prior to proton beam therapy. I don't want to go too much into detail. I just want to point out a few things. So you see that we treated one group E eye. We treated 2 children bilaterally. Youngest patient was 14 months old, oldest patient 97, and you can see that all of them had quite a range of different treatments before we started proton beam therapy. Here I would like to share with you a clinical example. On the top you see the irradiation plan of one of our patients. The gross tumor volume is shown in red, the clinical target volume is shown in yellow, and here you can note the sparing of the lens and the small bony window, and on the bottom you see the clinical appearance of our patient. So we had 2 recurrent tumors close to the optic disc, and after PBT we had a complete regression now over a follow-up of more than 16 months. Let's have a look at our results. Globe preservation rate was 60%. That means that 6 out of 15 eyes showed a need for secondary enucleation. Indications for secondary enucleation were optic nerve and choroidal recurrences, loss of tumor control with consecutive blindness in 2 eyes and a phthalmic globe in 1 eye. We found vital tumor cells on histopathological examination in 4 eyes, which is not surprisingly, as we saw that in 3 eyes on clinical examination. Here's one of the patients we enucleated due to a recurrence. Here on the left, you see the tumor recurrence of the centrally located type 3 regression 8 months after PBT. And on the macro photo, you see the enucleated specimen with a massive choroidal infiltration. What were our adverse events? We had a radiation-induced cataract in 4 cases. Those were patients where the lens could not be spared due to tumor localization. Time interval between PBT and cataract induction was 22.5 months on average. We had 1 patient with a perforated corneal ulcer and 3 patients with radiation retinopathy. Unfortunately, 2 children developed a metastatic disease, but then again, none of our patients so far developed secondary radiation-induced malignancies. So let's move on to the modified enucleation. Indications for that surgical approach are post-laminar optic nerve involvement. We all know that a tumor at the cut end of the optic nerve worsens the prognosis, as it is a known risk factor for metastatic disease, and therefore upfront enucleation without any neoadjuvant chemotherapy allows the exact pathological analysis of extraocular intention, and that is the key to management with appropriate surveillance and adjuvant therapy. So what was our treatment technique? We did the initial surgical steps of enucleation with disinsertion of all muscles. Then a lateral orbitotomy by a bicoronary incision was performed by our colleagues from oral and maxillofacial surgery. A long optic nerve stump was cut and completely removed along with a globe, and in all cases we used an implant. I would like to show you some pictures of this treatment technique. On the left, you see the initial findings of the group EI, and on the right, you see the marks for the bicoronary incision. So it's a large surgery. The surgical access was carefully prepared, and then the lateral orbital bone was removed. You see that here. In the next step, the optic nerve was located and transected and completely removed along with the globe. The bone was then refixed, and the access routes were closed. And on the right, you see the post-operative picture of one of our patients only 3 days after surgery. So let's have a look at our patients. Recruitment period was from November 17 to December last year. We included 8 patients with presumed extended optic nerve involvement on MRI. Clinical features: mean age of our patients was 27 months. 8 or all patients were suffering from unilateral disease with group EIs on initial presentation. 3 patients had a pre-enucleation chemotherapy for various reasons, whereas we did an upfront enucleation in 5 patients. Here, one clinical example. On the left, you see the RETCAM images of an advanced retinoblastoma, and on the right, the corresponding MRI scan. And here you see the intraocular tumor masses and the presumed optic nerve involvement. Let's have a look at the results. In the group of the children that received pre-enucleation chemotherapy, we found no signs of optic nerve involvement on histopathological workup. Those were 3 out of 8 children. On the 5 children where we did upfront enucleation, we found an optic nerve involvement in 3 cases, whereas the evaluation on the MRI scan was false positive in 2 patients. Here you see a histopathological slide of a massive optic nerve involvement. Average length of the detached optic nerve was 11.7 centimeters, ranging from 7 to 13 millimeters. The cut end of the optic nerve was free in all cases. We had an indication for adjuvant chemotherapy in 5 patients. Those were all patients with an N2 optic nerve involvement. None of the patients received an adjuvant orbital radiation, and unfortunately 2 of our children died due to a leptomeningeal dissemination. So to come to an end, I would like to summarize that PBT is an effective rescue therapy in advanced retinoblastoma eyes with no other treatment options. Our preliminary data suggests that the risk of radiation-induced secondary malignancies is significantly lower when compared to EBRT. And the modified enucleation allows pathological analysis of extraocular intention, which is the key to adequate surveillance and adjuvant therapy. Thank you very much for your attention. I'm happy to take questions.
Yeah, thank you very much for this excellent presentation. As you already alluded, I think probably secondary malignancies would be on top of the list of the concerns. As far as I remember, this was also age dependent, wasn't it, in the original studies? Do you feel you have an age where it's safe to do it in any case and it's not influenced by the technique? Or what are your thoughts on this?
So we always try to have children at least 1 year of age before we do radiation of any kind. It really doesn't depend on PBT or EBRT, but sometimes you have to do that before they reach the age of 1 year. And for now, I can't answer the question whether or not we have an age where we have a lower risk of secondary malignancies. We only know that before the fulfillment of first year of life, it's difficult.
And the second part of the talk, the importance about knowing whether there's optic nerve infiltration before and how long it is, that basically would speak that every patient, if possible, should have an MRI beforehand. So centers shouldn't just go ahead and say, oh, this is a unilateral retinoblastoma, I just enucleated, even because with a regular technique, perhaps you can comment on that. What's your normal length of an optic nerve head with regular technique? And you probably would advise against that, doing it outside of centers then. Is that correct?
That's true. So in our clinic, all patients get an MRI scan before we do enucleation, just to make sure that the optic nerve is free or presumed free. And when we ophthalmologists do the enucleation, we get an optic nerve stamp 5 to 8, 9 millimeters if we are lucky. But then again, it gets complicated when you have a ophthalmic eye. Then it's a little bit more difficult. And then again, you're under pressure when you know that you need to get a long optic nerve stump. So when we have a longer optic nerve involvement on the MRI scan, we ask our colleagues to come and help out.
One question from the forum is it really, really, really necessary to do an orbitotomy, or isn't there any other way of long scissors or something that you could use?
I don't think so. Probably Mr. Bechrakis wants to answer again, but I would say no.
I don't think that you need to have a reliable length of your stump. If you have the impression on the MRI scan that there is a infiltration of, let's say, 5 to 6 millimeters of the optic nerve, I don't think there is any way that we ophthalmologists can be pretty sure that we will get this length of a stump. So I think it would be much too risky to just go on and make the surgery by ourselves. And as Eva just alluded, I mean, these eyes are really difficult to enucleate. They are large, usually they are larger than normal eyes for these small kids or babies. And the orbit is very narrow, and it's really difficult to get a long, to be sure that you will get a long stump. If you have the unfortunate situation that you will cut through the infiltration, then you will get in a lot of trouble with recurrence in the orbit. And I think it shouldn't. I don't think it's wise to risk this. So that's why we take this pretty major surgery. But and as you saw from the results, still there were 2 little children that lost their lives because of leptomeningeal dissemination. So even this is not absolutely sure that you will avoid metastatic disease. And there has been a paper showing that there might be this infiltration of the optic disc of the optic nerve very proximal to the eye, that the tumor will probably go through the meninges, the pia mater, through the arachnoid, and then well, you can only find this out by liquor puncture, and unfortunately we were not able to determine this beforehand.
So I presume in the cases with the disease, the infiltration did not go up to the cutting edge. The cutting edge was free. Oh,
yes.
Yeah. So then you couldn't prevent it, no matter how long you cut the optic nerve. One more question from the forum is a steel loop to cut the optic nerve head. Do you have any experience, or do you use just scissors? What's your comment?
I never used this loop. We only use scissors.
Yeah.
And in England, unfortunately for children, we have to use single-use instruments, which sometimes are not the best. Is that the same in Germany or in other countries, as far as you know, or you have proper German scissors that you can sterilize? Or
yes, we have proper scissors.
Okay.
So we use reusable scissors.
Okay. And the last question is, how high is the sensitivity of lumbar puncture to detect leptomeningeal dissemination? Do you know, is any research published on it?
Very good question. We want to work that up and have a look on how many children really do have vital tumor cells on lumbar puncture, but our feeling is that we don't see a lot of vital tumor cells, but we still do it when we before we start enucleation. It's part of the staging system when we treat group E eyes, but as far as I remember, we don't see almost any vital tumor cells.
Okay, and very last quick short question before Nikos wraps up. Any role of local chemotherapy in the orbital stump with methotrexate, soaking it or so, in case you feel there's a local dissemination? Have you known of it, done it, experience with it?
We don't do it. I have no experience with that. Sorry, I can't concrete comment on that.
Me neither.
Okay, thank you very much. That was a great talk and great discussion. Nikos, you want to wrap up?
Thank you very much to all the presenters. Thank you very much for all your effort that you put into this webinar. And thank you to SOE for allowing us to do this. I think ophthalmic oncology and pathology is a very special subfield in ophthalmology, and I'm really glad that there are a lot of people that were interested in this seminar and webinar. Hanno, many thanks to you. Many greetings to Liverpool, and please note that the webinar was recorded, so you can shortly you will be able to see this on the SOE website. And if you are kind enough, after this webinar, there will be a short survey at the end of the webinar. You could, if you have some time, you could complete this. Once again, thank you very much for everybody, and thank you, Hanno, and thank you, SOE.
Thank you all. It was a pleasure.